Okay, Brian's going to be talking smoking cessation treatments, readiness to quit versus readiness to change. I hope I read it okay. Thank you, Dr. Hurley.
Good morning again, everybody. So I'm going to talk about treatment. And I should have probably said this earlier, but I have no conflicts of interest to disclose. I don't get paid by anybody who's trying to sell you anything. Okay. What do you already know about readiness to change tobacco use? This is not rhetorical. What do you already know about it? It's hard. Huh? That everybody is interested in quitting. Everyone's interested in quitting. And, you know, it kind of depends on what you mean by everybody. There's probably some people who aren't interested in quitting. But many people, their motivation exists on some spectrum, right? I'm interested. It would be nice if I quit. I'm not ready to quit right now, but it would be nice if I quit. What else do you know about changing tobacco use? Yeah.
It's very fluid. It can fluctuate. Very ready one moment and not ready at all.
Yeah, readiness waxes and wanes. People are oftentimes ambivalent, right? They feel one way one time and another way at another time. Anything else? Yeah, sometimes there are crises. There's events. There's maybe a health condition or some reason, right? Somebody learns about a reason to change. So what I'd like to do is there's two exercises I'd like to do around how we talk with people about change. Would it be okay if we did those exercises together? I'm hearing no. Nobody says no. So in the absence of objection, here we go. I'd like those of you who are able to please stand. Thank you. And what I'd like you to do is to cross your arms and look down at your crossed arms and notice which is the arm on the top, which is the arm on the bottom, which is the one that's tucked in, which is the one that's kind of going through and up. Now, keep your arms crossed. I'd like you to do something really difficult. I'd like you to cross them the other way. Take the arm that's on the bottom, put it on the top, take the arm that's on the top, put it on the bottom, and sort of tuck it in the reverse. Okay. Now, sit with that for a moment. Sit with that for a moment, see how it feels. And here's the question. On a scale of 0 to 10, 0 being not at all, 10 being maximally motivated, how motivated are you to each time you cross your arms from this point forward, cross them this other way? 0. Low motivation. Okay, thank you. You can uncross your arms and have a seat. Low motivation. But let me tell you something. Let me tell you something about crossing your arms. If you cross the arms the other way, it helps open your mind. You get more flexible. It's good for you. And in fact, what if I gave you $100 if you agreed to cross your arms the other way? How motivated are you now? More motivated. More motivated. Okay. Well, hey, I'm glad you're more motivated because I have the solution. I will tell you exactly how to do this. I have a great idea. You don't even have to think about it. What we'll do is we'll go get some tacks and some super glue. And we'll put some tacks on the part of your arm where you usually cross your arms. And what will happen is when you cross your arms the usual way, you'll get it's a reminder. A reminder that you agreed to cross your arms the other way. And no thinking involved. I got this covered. So what do you think? Scale of 0 to 10. I've talked to you about the reasons. I told you how to do it. What do you think? Scale 0 to 10 around crossing your arms the other way. Low motivation. But this is really important. I've talked about benefits, including cash. There's no thinking involved. Just do it. I already told you how to do it, and if you're not, you're going to be stiff. What do you think now? Scale of 0 to 10. How motivated are you? 10? 4? 2? Who's higher than 2? Okay, a few hands. Who's less than 2? Like everybody else. Okay. So here's a question. When I'm persuading you to make this change, to cross your arms the other way, what did it feel like? It felt awkward. How did it feel? Uncomfortable. Awkward, uncomfortable. How did it feel? Patronizing, yeah. Yeah, it sure did. How did it feel? Silly? Unnatural? Hard to do. Okay. So what I'd like to do is a different exercise. And this is another exercise where you're going to have to pair up. So look around and think, who am I going to pair up with? And what we're going to do is one of the one person, is going to be the speaker. And the exercise is called Give No Advice. The speaker has to think something that is true in their lives, right? This is not a role play. This is what's called a real play. Something that is real in your life that you want to change, need to change, should or ought to change, have been thinking about changing but haven't changed yet, right? Something you want to change but haven't changed yet, and that you're comfortable talking about. You have to be comfortable sharing it, right? And then person B is the listener. And person B is to, and this is the hardest part, give no advice to the speaker. And instead, listen carefully with the goal of understanding the speaker's dilemma. Give no advice, but instead ask these open-ended questions. Say, why would you want to make this change? What are the 3 best reasons to do it? On a scale of 0 to 10, how important would you say it is for you to make this change? 0 being not at all, 10 being maximal. And when they give you a number, let's say 5, say, why is it a 5 and not a 2? Or I'm sorry, why is it a 5 and not a 0? Whatever number they give you, say, why is it that number and not a 0? And then ask, so how might you go about making this change in order to succeed? Listen carefully to the person's responses, and then give back a summary of what the person told you. And then at the end of all that, then ask, what do you think you're going to do? So it's a bit of a script that the listener is supposed to follow. And the most important thing is to give no advice. This is, I know it's a little bit small, but this is the instructions. Speaker A, person A, thinks about something they want to change but haven't changed yet. Listener, person B, follows the script. Why would you want to make a change? For the 3 best reasons to do it, scale of 0 to 10. How important do you say to make a change? And why is it whatever it is they give you, not a 0? And then ask, how might you go about it in order to succeed? And then ask, what do you think you're going to do? Any questions about this exercise? It usually takes about 5 minutes, and we're only going to have time to do it in one direction, unfortunately. So there will be one speaker, one listener, and we're not going to be able to switch. Sorry about that. Any questions before we proceed? All right. Go for it and give no advice. If you don't have a partner, raise your hand. We got 2 more minutes. 2 more minutes. One more minute.
So fast.
All right. Thank you for participating in this exercise of give no advice. And for those of you that have gone to motivational interviewing trainings before, you'll recognize this as something called a taste of motivational interviewing. And I know I didn't give you a ton of time, and we could probably do this for the next half hour, just be talking about, the change we're going to make in our lives. But actually, what I want to do is ask for the people who were speakers, for the people that were sharing the thing that they're thinking about changing, what did it feel like to participate in this exercise? It felt good? How else did it feel? You felt heard. You felt that you were listened to. How else did it feel? Yeah, there's something really, so you said, oh boy, I'm accountable. There's something very powerful about talking about change and actually saying the words to somebody else. It's a very powerful experience. Yep, over there in the back. Yeah. Where was the solution coming from? From you. It was coming from you. Yes.
Also, it may or may not be setting on very 6 on, 5 on.
That depending on your readiness, let's say somebody was like a 2, it may not be time for specifics, right? It may not be time for planning. What else? Mm. Mm-hmm.
And they don't know me, but someone else that they know. Oh, she said that before, but
yeah, the comment was that talking to somebody who's brand new who doesn't say, well, you've said that before, but having a fresh chance to articulate it was really powerful. Yeah.
Kind of exhausting. That's like one. Like, think of something vaguely as opposed to actually having.
Yeah, that having a set of open-ended questions put a lot of work on you, and you had to be the one to sort of articulate the specifics. Now, what did it feel like to be the listener, to be the one listening? Yep. It was hard. Wasn't it hard not to give advice? We just enjoy it so much. We enjoy telling people what to do, It's in our nature. But what else was it like to be the listener? Yeah. It felt unnatural to ask these open-ended questions without necessarily giving your input. Yeah. Any other reflections? You felt compassion and empathy. Yeah. Create holding space for somebody, for them to give them the runway to be able to articulate their thoughts. Yeah, on the back and then over here. Mm-hmm. Yeah, when you're working with somebody, you realize that they have the capacity for change inside them. It's actually very humbling. Right? It's very humbling to see that, right? Because you're like, wow, you really have it. And up here. Mm. Yeah, there was sort of the challenge of like, hey, come on, like you know what this is, like say the thing I'm waiting for you to say, right? And needing to sit with the acceptance, right, that people are autonomous, right? This is her journey. This is her journey. Okay, so I know not everyone is here as a clinician, but imagine that you're in a helping profession, right? You're you could be a provider, you could be a clinician, you could be a community worker, you could be a resource specialist, you could be a peer, but let's say you're a helper, and you have the choice. I'm going to walk into, say, a room or a setting where the people that I'm supposed to work with feel condescended to, feel uncomfortable, feel awkward, feel like the reasons that somebody's talking at them are coming from them, versus you go into a situation where people feel heard, they feel like they have to do the work, where they feel that, a sense of agency and ownership over their trajectory. Who would you rather be working with? The room A, people awkward, or room B, where people feel motivated? B, right? Room B. But who has control over that? We do. We set the context, right? And so the reason that I start out a talk that could very easily just be a medication talk with a taste of motivational interviewing is because how we talk to people about change actually shapes how people talk about change. It shapes how people talk about change. So why do people change? Well, change actually happens all the time. Treatment can facilitate change, but one of the things, for those of you that work in a helping capacity, that we oftentimes want to fix things. We say things like, "Oh, I got it. Just do this, 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 this. Here, I figured it all out for you." And what are you doing? You're essentially putting metaphorical thumbtacks on people's arms, and people are like, "Whoa, whoa, 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 whoa. This feels awkward. I feel condescended to. I don't feel heard," right? And so the righting reflex is a common attempt to fix things. And not only is it oftentimes counterproductive, because people are much more likely to do the things that come into their minds than what, we come up with, but it can actually be counterproductive, because what happens, and this happens with smoking all the time, is you need to quit smoking, but I like it, but it helps me with stress, but I can't imagine not smoking, but I gain weight. And what are they doing? They're articulating what's called sustained talk. They're articulating the reasons not to change. And the thing that they're more likely to do is the things that they hear themselves say. It's not the things that they hear you say, it's the things that they hear themselves say. So I would argue that actually rushing right to planning before you know it's time, right, to this point, before you know it's time, is not only irrelevant, it can actually be counterproductive. It might make people less likely to make a positive change. Versus when you're invited and when the reasons and the ideas of motivation come from in my case, I'm a physician, so I use the word patient, the client or consumer, or there's a bunch of different terms we can use, but come from the person that we're privileged to serve, that's a lot more powerful. And so there's a couple of techniques that I've found effective in order to elicit something called change talk. One is called an amplified reflection. I don't say, "Are you ready to quit smoking?" until the person I'm talking to says, "I'm ready to quit smoking." Once I know that it's coming from them, fine, I can get on board with the word quit. But until I know that that's where their head is, I'm not going to use the word quit. I'm going to use the word change. And I might even say, "What thoughts do you have about changing your smoking?" And the person I'm working with might say, what do you mean changing my smoking? And I'd be like, "Yeah, like you smoke a pack a day. Is it time to go to 2 packs a day or 3 packs a day? Like put like a scuba mask on and just breathe smoke in all the time? Like are you really like, is that where we're headed?" And the person, if I've done it right, and the person doesn't think I'm mocking them, but actually, that it's done out of a genuine curiosity. I'm coming in with a genuine curiosity. They'd be like, "Well, no, I couldn't afford that number of cigarettes. I know I would smell bad. It'd stain my teeth. It'd be bad for my health, And all of a sudden, the reasons for change are coming from the person I'm working with and not me. So I sit here and think cancer, heart disease, strokes, right? Lung disease, right? Those are the things I'm thinking about. For them, it might be, I just want to walk up some stairs without huffing and puffing. I may not want to smell. I want my teeth to look different. right? I don't want to smell, right? That may be the things that are important to them. And I want to work with the things that are important to them. And it doesn't mean I can't give advice. I know the exercises give no advice. You can give advice, but you can give advice when you have permission to give advice, right? You can give advice when you ask, is it okay if I give you advice? I have some thoughts on this. Is it okay if I share my thoughts with you? And then you give a couple really clear, salient to the person you're talking to ideas, and then you ask, so what do you think you're going to do? Like, or what do you understand? What do you understand? Like, so you're always going for something called change talk. This means that it's not that people are unmotivated. People are always motivated to something. It may not be the thing that I care the most about. It might be the thing that they care most about, right? I might care about quitting. They might say, I'm going to go down by 1 cigarette a day next week. That may be where I'm at. Great, right? People are always motivated to something. And rather than saying, oh, this person is unmotivated, they're pre-contemplative. I hear that all the time. I actually stopped using the Prochaska di Clemente, what are called stages of change, or pre-contemplative, contemplative. I don't use that anymore because it labels people. And what I do instead is I listen for what is this person motivated for, what do they want? So change talk, and I've sort of already kind of implied what these mean, is simply what somebody says that talks around change. And sustained talk is the things that people say that talks against change. And so the strategy of interacting with people is how we go from wrestling, which is, you need to quit smoking. I don't want to quit smoking, but you have to quit smoking. But I can't quit smoking. But here's the reasons to quit smoking. I hear your reasons, but there's reasons to keep smoking. Well, you need to take patches. I don't want to take patches, right? It feels like wrestling, right? To dancing. Oh, like somebody says, I don't want to use patches. Great, you don't want to use patches, and you want to try to find something else that's effective, right? That's a dance. That's what's called a dance, complex reflection. They didn't say they wanted to use something that's effective. I said that, but I did it in a reflective way. All right, so we've already kind of done change talk. Motivation and doing is a particular focus to change, and people are generally better persuaded by the reasons that they have themselves discovered than those that have come into the minds of others. This is the difference between, you know that somebody's giving you change talk when they say what they want, what they can do, the reasons to change, the need to change, or if they're like, this is what I've decided, I've started to, I've taken the steps to, I got this, I went there, I did this, and then sustained talk is anything other than that. Sustained talk is I can't, I shouldn't, I don't want to, not a good reason, right? And change talk and sustained talk oftentimes come mixed together. The key is selectively reinforcing the change talk. So how do you elicit change talk? Ask evocative questions. We've already done this, but there's something called the readiness ruler. So in order to make any change, people have to want to, and they have to be able to, and both have to be true. So one way of assessing that is by asking, on a scale of 0 to 10, how motivated are you, or how important is it for you, right? It's the same way of asking it. How important is it for you to stop smoking, or to change your smoking, or pick your behavior? Could be, go to your doctor's appointments, right? There's a lot of potential, targets. A scale of, and I like to include 0, but a scale of 1 to 10, how important for you to stop smoking? And then when somebody gives you a number, you say, well, what makes it a 6 rather than like a 3 or a 4? Because the next thing they'll tell you is why it's important to them. It might be intuitive to say, what do you mean 6? Why isn't it a 10? But the reason it's not a 10, what that'll do is evoke sustained talk, right? People will just tell you why they don't want to. But you want to try to get why they do want to. So if somebody says I'm a 1, I say, why is it a 1, not a 0? Somebody tells me it's a 0, I say, why is it a 0 not a -1? I always go lower. And then there's the confidence rule. On a scale of 0 to 10, how confident are you could quit smoking? And then you ask, and what would it take to go from 6 to a 10, right? You're always trying to evoke for what, like, abilities and what it would take. Okay. So I have 20 minutes, if I'm getting my time right. Yeah, sure. About 15, 20 minutes. And so I'm going to go through everything else. And the everything else that I have planned is to talk about the core components of smoking cessation. And the core components of smoking cessation are meds, counseling, and support. And most things can be lumped into what are called domains, these domains, right? So the meds are meds, counseling is skills, and support is everything else. Support is, usually what we think of as the entire psychosocial infrastructure that people need to support their well-being. So are you housed? What is your family like? Are you being traumatized? Do you have food? Like, it's the whole sort of context for living. And people do need all three to be addressed to be successful, but not everyone needs all three of these exactly the same way, right? There's some people that have a strong set of skills, and they have strong psychosocial support, and the medications help are like the key factor that helps tip them over from smoker to non-smoker. So some people who will never take a medication, they don't want to take meds, it's not for them, they don't like it, and it's really skills and support, right? But this is the menu, and I want everyone to be offered everything on the menu, which is why we've structured our program the way it is, our study the way it is to link people to counseling and support. But I want to acknowledge there's some people that take smoking cessation meds alone, and that's okay. Some people do counseling alone, and that's okay. But if it's not working, I want people to have all the options, right? And so this is a slide from the UCSF, and actually Chad Morris down at University of Denver, who's Colorado, Denver, kind of stole this from UCSF, so I stole it from him. So tobacco use disorder has a physical dependence part, right, which is our cycle of intoxication withdrawal with nicotine. We smoke, intoxicated with nicotine, but what comes up must come down. Our body metabolizes out the nicotine, and then we're in withdrawal, right? And that cycle is really stressful. And in fact, if you can get somebody out of that cycle, we see that quitting smoking can be as effective or even more effective for anxiety and depression than like antidepressants. If you can just get somebody out of that cycle of nicotine intoxication withdrawal, it can have a huge impact on reducing stress. Now, you might say, wait, did you just say quitting smoking helps with depression? Well, once you're quit, it helps with depression. The actual quitting is stressful, and I'm not going to lie. Like, that will increase stress. But the idea is once you're through the quit attempt, a lot of people find that overall their mood is better and their stress is less. But the physical dependence is not the only piece. Addictive behavior is learned. It's stored. We remember this sort of pattern of smoking. And we have to address that behavior pattern too. And the best treatment addresses both the physical, right, the pharmacologic, the sort of brain changes that come with repeated exposure to nicotine, and the behavior that we've become accustomed to. Okay, so these are the evidence-based behavior change interventions. It includes CBT, brief interventions actually seem to be effective, individual counseling, psychoeducation groups. That's what we're promoting within the county, psychoeducation groups. But there's lots of models of peer support, tailored, you can do web support, you can do phone support. There's a lot of really validated approaches, and many of them are available on NoBuds. NoBuds does not offer individual face-to-face counseling, but you can get counseling on the phone. You can get a whole number of resources. So once again, California Smokers Helpline. This is what's called the 5 A's. It's the components of what's called a brief intervention, which uses a bit of motivational interviewing where you ask, and then with permission advise, and then assess, and then assist, and then arrange. And now I do want to talk a little bit about the medications for tobacco use disorder. And there's 3 molecules. Those 3 molecules are nicotine, bupropion, which goes by the trade name Zyban if it's being used for smoking, or Wellbutrin if it's being used for depression. It's the same molecule. Same molecule is called bupropion. And varenicline, which goes by the trade name Chantix, right? So these are the 3 molecules. Now, nicotine comes in a bunch of different formats: patches, gums, lozenges, nasal sprays, inhalers. And in those, there's a bunch of patch brands. There's a bunch of, lozenge brands and gum brands. So there's a bunch of different formats of nicotine replacement therapy, but it's the exact same molecule. And this is where these medications seem to work. They seem to work on both helping with craving, and they also work on the part that helps blunt the reinforcement, that is the high that you get when you smoke cigarettes. It can block this part right here where you use and then you feel better. It can help blunt that. So it reduces the reinforcement for the rewarding impact of cigarettes. So it helps block cravings and it helps block the reward of cigarettes, or how these medications are thought to work. I'm prescribing you a patch to help quit smoking. Please wear it over your mouth. All right. So which is the best? Which of these medications is the best? It's the one the patient takes. It's the one the patient takes, right? So there is comparative data, right? Don't get me wrong. But if somebody's not going to take it, it doesn't matter how good it is in a clinical trial, right? The best meds is so I put patient preference as number 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. The first 10 most important things is patient preference, or client preference, or consumer preference, or then, how comfortable is the clinician that might be managing the medication with the medication? There's some patients that can't take every medication, right? Not every medication is appropriate for every person. If somebody's had a really good experience or a really negative experience with medication in the past, that's just important information to consider as to, should we, if you use a medication before and you quit for a long time, maybe that's the medication to try again. And then patient characteristics, concern about weight gain and a history of depression can be helpful. Knowing whether or not you should think about an antidepressant medication that can also help with smoking. So the patches come in 7, 14, 21, and 28 milligram strengths, and it's pretty easy to remember how to dose it. There's 1 milligram per nicotine, 1 milligram of nicotine per cigarette, and so you just match the milligrams in the patch to match the number of cigarettes that you smoke. And ideally, you want to actually take a patch that's a little stronger than the number of cigarettes you smoke because, and it might be counterintuitive, because you really don't want to be in withdrawal, right? The goal of the patch is to keep people out of withdrawal. And the patch is different than smoking. When you ignite a cigarette and inhale the smoke, the nicotine goes right into your lungs, that goes right into your heart, that goes right into your brain. Smoking is the fastest way to get something into your body. Faster than injecting, interestingly. So it goes right to your brain when you smoke it. When you put on a patch, it takes a while to kick in. You don't really get that immediate reinforcement. So it's hard to get addicted to nicotine patches the way it's easy to get addicted to smoking because of that immediate hit, right? That immediate reward. And that's the advantage of using the patches for withdrawal management is that you can then taper it down slowly over time. So rather than the cycle of I'm intoxicated then withdrawal, you can just break that cycle by just giving somebody kind of a boringly low, boring level of nicotine. Just sits on there and you just get that level of nicotine throughout the day. But the truth is, oftentimes the patches aren't sufficient, right? You can give somebody the patch and it helps, but it's oftentimes not enough. And medication-wise, I actually recommend that you combine an additional nicotine product on top of the patch, which is the gum or the lozenge, or the nasal spray or inhaler. The nasal sprays and inhalers are not covered by Medi-Cal. You have to fill out a prior authorization. But the gums and the lozenges are over the counter and are certainly paid for by Medi-Cal. And you can use it for cravings. You crave a cigarette, and then you can use the gum or the lozenge to give yourself a small bit of extra nicotine to help tamper down the craving. It doesn't usually take the craving entirely away, but helps mitigate it and give somebody enough reinforcement that they don't reach and grab a cigarette. Bupropion is just a daily medication. You take it, depending on the formulation. I use the extended release that has I put XR here, but it's actually XL. It's a once a day, but you can use, there's a twice a day medication, SR, that you can use. And the usual dose is 300 milligrams a day is the maintenance dose for most people that take Zyban. And then Chantix, right, or varenicline. It's the newest of the smoking cessation medications. And what it does is it blocks the nicotine receptor, so it keeps other nicotine agents from binding to it, but it partially activates it. So you get a little bit of a nicotine effect, not terribly high, but if you smoke on top of it, the patients of mine that take varenicline, when they smoke, they're like, this doesn't taste right. This doesn't feel good, or doesn't feel as good, right? And I had this one patient, I prescribed her, she was a pack-a-day smoker, and I gave her varenicline, and she was down to 5 cigarettes a day. Right, from 20 cigarettes a day to 5 cigarettes a day. And she was mad. She was like, I thought this was going to make me stop smoking. And I was like, well, you do still have to quit, right? It won't make you stop anything, right? But the medication alone, even though she wasn't necessarily planning a quit attempt, I mean, we still, I gave her instructions on quitting, but she just expected it to just work magically. But even that alone cut her smoking down by 3/4. Now, not everyone responds to varenicline the exact same way. And you start at a relatively low dose and titrate up. This is the chart that I usually go to around the comparative efficacy. And we see that when you combine the patch with the gum or the lozenge, it seems to work better than almost anything else, right? What's called combination nicotine replacement therapy. Better than any one nicotine medication alone. But varenicline or Chantix on its own actually seems to do pretty well. And then and then bupropion on its own is a little bit less. And when you get down to placebo, and this is people who have stopped smoking at 6 months after taking these medications. I'm not going to go through this whole thing, but actually our county department health services has a recommended protocol. And so this is just kind of what it looks like. I'm not going to go through it in a ton of detail. But that's a protocol that I recommend. I'm going to put this back up and then answer this question. Yep. So the side effects of adding more nicotine are the side effects of nicotine. So the side effects so there's no medication that's side effect free. All medications have side effects. The side effects of nicotine are if you swallow it, you can burp, right? So there's a sort of a burping effect. It can raise blood pressure a little bit. And then it kind of depends on the format. So some people get headaches. If you take it at night, if you have the patch on overnight, it can give you nightmares. For some people, if you take it overnight, it can cause insomnia. And the other thing about nicotine is, I sort of mentioned it can raise your heart rate and blood pressure a little bit. It's not recommended in people who just had a heart attack. So within 2 weeks of when you've had a heart attack, it's not recommended. Doesn't mean you can have heart disease and use it. It's not that you can't, but it's generally recommended right after you've had a heart attack to not be on a nicotine replacement therapy product. And if you take sort of too much nicotine, people sometimes feel a little I don't know what the right term is, activated or buzzed, they're kind of they feel a little wired if they take too much nicotine. Fortunately though, nicotine doesn't last that long in your body. So your body will metabolize it off. So if you're feeling too activated, you can pull the patch off and stop using the gum, and then you'll return to normal usually within an hour or two. Bupropion, or Zyban, has the side effects of increasing anxiety. Sometimes it can cause tremor. If you take it late in the day, it can cause insomnia. And headaches and upset stomach, which are the common side effects with most medications. And if you have bipolar disorder and you're not on a mood stabilizer, it can cause mania. It's a very elevating antidepressant. And I've had patients have had dry mouth on it, which is not an uncommon side effect. The side effects of varenicline or Chantix are most commonly headache, upset stomach. Some people get insomnia. Some people get nightmares. It can rarely cause suicidal thoughts, and in fact, this was highly publicized, and there was a big black box warning. Interestingly, when they did a big review of psychiatric effects of varenicline, the people that took varenicline didn't end up in the psych hospital. There weren't any real bad outcomes related to varenicline. Just people, there was it was rare in the single percentage range of suicidal thoughts. But it can happen with varenicline, and there are people who have become agitated on varenicline. But again, those are people that might have been agitated anyway, right, depending on their pre-existing psychiatric conditions. And then the other thing that varenicline, there was a big study showing that there was a very small, it was a fraction of a percent increased rate of strokes and heart attacks. And the FDA kind of did this big review and then said, well, this medication, I guess, had a non-statistically significant increase in strokes and heart attacks, but that the benefits of quitting smoking outweigh the risks. And so, the black box warnings for both suicidal thoughts and for cardiovascular disease have now been taken off of the label for varenicline. And I use varenicline with people with schizophrenia and serious mental illness all the time. And so far, so good. I've made more people manic with bupropion, and I've had more issues with that than I have had with varenicline. Okay, so this is a recommended medication strategy. I don't recommend vapes as a tool to quit. The reason is that vapes aren't designed or manufactured as a smoking cessation agent. They are manufactured as their own addictive substance, right? So what happens is it's perfectly feasible to transition from smoking to vaping, and vaping may be less dangerous, right? We don't know all the studies, but the polycyclic aromatic hydrocarbons that are in the smoke, that's the stuff that gets your liver inflamed. That's why psychiatric medications don't stabilize as well in smokers, is because their liver is metabolizing faster because they're actively trying to get through all the polycyclic, all the stuff that's in the smoke. But many people that transition to vaping, they just keep vaping. And our lungs really aren't made to take in polyethylene glycol and the other solvents that, again, it's new enough so we don't know all of the health effects. But vaping is likely not as healthful as not vaping. And actually, this is the Lancet article that e-cigarettes were associated with less quitting among smokers. Does anyone know who this is? Bill W. What did Bill W. do? Alcoholics Anonymous. This is Bill W. He created the 12-step program, Alcoholics Anonymous. How did Bill W. die? Emphysema. Bill W. died of emphysema. I have been to AA meetings. For those of you that feel comfortable sharing, who've been to an AA meeting. Has anyone been to an AA meeting? What happens at AA meeting? Well, there's sharing. There's people talk, right? It's coffee and cigarettes. And so here's the irony. Here's a guy, how many people have stopped drinking thanks to 12-step? Millions of people right across the world. I mean, it's in most countries now. Anywhere you can go, you can find a 12-step meeting. I mean, this guy has this extraordinary legacy, and the thing that got him was smoking, and that's the irony, right, is that we sort of think of, let's quit one thing at a time, but the truth is, people with substance use disorders and people with mental illness, that's the people who are still smoking, right? That's the people who are really highly dependent. Anyway, that integrating these treatments, right, the counseling, the support, and the medications into smoking cessation, into mental health and into substance use disorder treatment is imperative. We know that smoking cessation during mental health treatment reduces depression, anxiety, and stress, actually in this study more effectively than antidepressants. Smoking during addiction treatment actually helps improve people's rate of response to their primary substance of choice. So if you want to stop drinking and smoking. If you want to stop using cocaine, stop using cocaine and stop smoking. And that actually it enhances the substance use disorder treatment outcomes. In California, if you go to smokefree.gov, that's the U.S. Portal, which links to the California Smokers Helpline. If you want a 12-step program for nicotine, there's Nicotine Anonymous. UCSF has a really strong smoking cessation leadership program, and I don't recommend light cigarettes, natural cigarettes, smokeless tobacco, snus, which is like a chew, or e-cigarettes. And the thing that I think is most important when I talk to people with smoking cessation is really persistence, right? That it's easy to say, oh, this person's not ready. They're not interested. You know, this is not the right time. But if we're continually persistent at asking permission, I'm not saying to tell anybody to smoke, but evoke from somebody their readiness. Oftentimes, we talked about this ambivalence, right? It kind of waxes and wanes. We don't miss out on an opportunity to capitalize when somebody's really ready to make some positive change. And it's hard to imagine a more impactful positive change on health than to reduce or eliminate smoking. So with that, this is my email address. Thank you so much for your time and attention. Thank you. And then there's a couple questions. Question over here?
Cultural aversion to Western medicine among a lot of our clients. And on the topic of medications, I'm wondering if there are any studies that you see that show the comparative efficacy of alternatives to medicine, like yoga, meditation, acupuncture, or even homeopathic.
So I should say I would have to go back to the literature to give you like a comparative analysis of, you know, acupuncture, yoga, other, say, non-FDA regulated supplements as compared to the FDA recommended medications. I know the FDA recommended medications are actually quite impactful, right? When you look at sort of changes in rate, I mean, you can increase somebody's chances by over 50% just with one of these medications alone. And I haven't seen that level of response with other types of interventions. That said, if somebody says the thing that's going to help me with my stress is yoga, then have them do yoga, right? Auricular acupuncture on the ear actually there's a number of trials supporting that it can be helpful with certain types of addiction. I just don't know. I didn't come prepared to know. I can't give you the evidence on that other than auricular acupuncture I think is a promising treatment for addiction in general. And there are people who respond to all kinds of things. And so, you know, there's protocols around hypnosis and other stuff like that. And so the most important thing I think is for people to know know the treatments that are available, especially the FDA regulated high impact treatments. And when they're ready to make other changes, to give it a shot, right? Because I'm short of something that's going to be clearly harmful, right? To make sure that, you know, because not everything is equally helpful. But when people want, if doing yoga or one of the other alternative therapies is really the thing that gets the person to start making positive change, then I think it's a reasonable place to start. And over here? Oh, over here?
Smoking. How do we explain the fact that most mental health facilities offer cigarettes to these patients?
So the question is, how do we explain that most mental health facilities offer cigarettes and make actually a lot of efforts to accommodate smoking? And there's actually been lawsuits here in LA where judges have said it is a right for people who are being involuntarily committed to psychiatric treatment to be able to access tobacco products, which is, I think, a bad legal precedent. But the political will around creating smoke-free institutions is increasing. I think that we're unlikely to see many court cases trying to defend people's right to smoke at this point. And I think what it takes is champions at those institutions saying this isn't acceptable, that we can no longer foster tobacco use disorder in our facilities. And the idea that, oh, we're in an addiction treatment facility and we're gonna focus on all the non-tobacco addictions and we're not gonna touch the tobacco addictions is, I think, just ridiculous. So, I think, how are we doing on time? All right, we'll take 2 more questions. We'll go over there.
And then over there, you want to go ahead, please?
You kind of answered the question
Okay.
on the culture. When I went into rehab, they had smoking
All
breaks and everything
absolutely.
all the time. And how do we change that culture? So
Yeah,
you answered it.
Yeah.
So I think everybody in the room has to be part of this change of culture. That's what we're here for.
Yeah.
And you to realize, you know, if you're dealing with people's mental health, and a lot of people I think are, don't encourage them, get them to stop it. To help their mental health.
Right. Up here and then over there?
Next, over here.
What? Okay. Yep, we'll go over here. It's all right.
Over the left, right there.
I don't have an answer to any of this, but I just want to throw out a few struggles. I was a program director for an IMG step down, which is transitioning people with schizophrenia that are been in locked facilities back out into
Community, yeah.
yeah. Most of our clients smoked, and we were trying to become a non-smoking facility. We were not a locked facility.
Yep.
And so when we stopped having a nice little comfy smoking area, told them they can't smoke on the property, it forced them to the streets, where then they're now involved with gang members and they're involved with crime again because they're easier prey. I've even had clients go out to the local bars and do prostitution for cigarettes. Also, many of them were conserved with the county, which also when they arrived to us, they came with no money and it took months
Yeah.
to get their money and to keep them from going on the street to hustle for cigarettes. We ended up creating jobs on site where they earned gift cards, which they used to buy
For cigarettes, yeah.
So it was, as much as we wanted to stop the smoking there, it became very dangerous to not allow them to smoke in the state.
So I think those comments are really well said, and there's not an easy answer. What I think would be logical from my perspective is to make smoking as inconvenient as possible, but still give people the opportunity. Like, it's sort of like a safe injection site, right? Like you need to give people a safe space, you know, safer than having to leave, you know, and escape the safety of the step down if they've decided that they're going to go use, while making sure to very assertively at every opportunity, hey, rather than smoke, here's our, you know, array of patches, gums, lozenges. We can hook you up with a prescriber right away. You know, here's the counseling that we can, you know, like very assertive treatment to make the treatment as convenient as possible. The tobacco use as inconvenient as possible, while not setting up a situation where people necessarily will be forced to go do unsafe things in order to serve their addiction. Does that make sense? Yeah.
What I like is I made it possible for them to at least earn
Yeah.
a card and go buy it. I like the reward for if you don't smoke.
Yeah, if you don't smoke, you get a contingency. Yeah. Yeah, the contingency management would be a really strong program.
We'll do one more question.
One more question. And then I'll be here. So I'll be here during the break. We can talk.
We'll get you next time.
Is there anything in particular that prescribers need to be educated on? Because I find with in substance abuse and even with the serious and mentally ill that, you know, when someone says yes, you need to be on it, otherwise forget it. The opportunity is not going to show up for a while.
You made the most important point, which is acting fast, right? Acting when somebody, at the moment somebody is interested. These medications are not technically complicated. I mean, this is not a how to prescribe these medications talk, right? There is a how to prescribe these medications talk, but fortunately, they're not actually terribly complicated to use. And when somebody's done, I think what we find is when somebody's prescribed to like at least 4 or 5 patients, then that's kind of enough. That's enough of a lead-in for people to get the hang of, you know, what people commonly experience. I'm out of time. Thank you so much.
If you can just add, Brian.
Yep.
We are offering symposiums on really how to be a smoking cessation, really nitty-gritty details.
Yeah, we
You
have.
can contact Brian. He can give you information about that.
Yeah, we have plenty of presentations as well as the county inspector practice, so they'll walk somebody through offer this and then offer that, like a prescribing strategy. So, and that's freely available. Happy to distribute it. All right, thank you
Great
again so
questions.
much.
Great job, Ryan. Thank you. So come back at 10:40, 10-minute break. Sorry it's short, but please come back. There's, I think, some breakfast still out there also. Nice job, Guinea. Good job.